Dr. Steve. Thank you.
السيشن الجايه للدكتوره فاتن فوزي بروفيسور اوف راديو دايجنوزز اند ايمجينج جامعه الزقازيق بعنوان emergency neuro imaging cases. اتفضلي يا فندم.
Thank you, Chairman. بسم الله الرحمن الرحيم. سعيدة بالمشاركة في المؤتمر الثاني قسم الأشعة التشخيصية طب بنها، وشكري الجزيل لبروفيسور هشام الشيخ على الدعوة الكريمة وكل الستاف في قسم الأشعة طب بنها. I will present neuro cases in non-traumatic, non-stroke emergency setting, and I would like to shed light on the importance of the clinical data obtained from the patient and detailed physical examination for the proper selection of the imaging modality of choice in order to design the protocol of the study, a good analysis of the image or good analysis of the MR sequence in order to reach proper diagnosis, narrow the differential diagnosis. Case 1 is for a 39-year-old female with a 2-week history of postural headache, nausea, vomiting, dizziness, tinnitus, and double vision with dizziness. There is a clinical clue. What is the clinical clue? The clinical clue is the positional or the postural headache. This should raise the diagnosis for intracranial hypotension. So, MRI will be your imaging modality of choice. You should not only interpret or evaluate the parenchyma of the brain, but you should look for the extra-axial structures also. Here, there is enlargement of the pituitary gland, again with thickening of the pachymeninges, effacement of the cortical sulci. So you should complete the study with gadolinium. The gadolinium shows, or the post-contrast MRI shows, enhancement of the enlarged pituitary gland, engorgement of the venous sinuses early, and we are in the early or the arterial phase. So this will confirm the diagnosis of intracranial hypotension with subsequent increase in blood volume. The second step is to confirm the entire neural axis, which is MRI for the spine. And not only MRI for the spine with the traditional sequence, you should stress on sagittal and axial fat suppressed image or the stare image. Why? Because some of cases of intracranial hypotension could be subsequent to CSF leak post-surgical, or even it could be iatrogenic or induced by the presence of osteophytes. So here, this is the line, this thin line is the dura, and here there is abnormal CSF signal in the ventral and dorsal aspect of the cord, and they are located in the anterolateral aspect of the cord after we suppress the fat signal. So here there is CSF leak. We are in need to confirm with CT myelography that confirms the presence of extravasation of the contrast, and on the bone window we can detect multi-level osteophytes, and here this is osteophyte is the responsible for the dural tail. So that is not spontaneous intracranial hypotension, but it is subsequent to osteophyte. Why this case is emergency? Because it is in need for immediate blood patch repair, CT guided, by means of the CT-guided blood patch repair, or even we are in need for immediate surgical repair of the dura. So intracranial hypotension is an emergency situation, and it is increasingly recognized nowadays with unique symptomatology and the imaging features. The risk of this case is cranial nerve palsy subsequent to the brainstem distortion and sagging, and there is a risk of venous sinus thrombosis. So you should ask for or to recommend MRV to confirm the venous sinuses. The second case is for a 65-year-old female with poorly controlled diabetes, present with transient flashes of light followed by severe visual loss. MRI was done for this patient. On T2 and flare, here there is bilateral, nearly symmetric hypointensity, cortical and subcortical, in the occipital lobes. The clue clinically here is the poorly controlled diabetes. And the clue clinically here is the T2 hypointensity. What is the cause of this T2 hypointensity? So it's not ischemia, not breast, as breast and ischemia will result in high signal intensity, not low signal intensity. On the corresponding diffusion images, here there is restricted diffusibility, again with gyriform enhancement on post-gadolinium imaging. We confirm that it is not ischemia by the presence of normal MRE. So what is the scenario? The scenario here is diabetic patient with predilection to metabolic changes to the occipital lobe in a condition known as irreversible cortical blindness in non-ketotic hyperglycemia. So in every patient, diabetic patient with uncontrolled diabetes, there is high predilection to the occipital lobe deposition of minerals or even osmotic dehydration with characteristic T2 and flare low signal intensity. So you have to pick up any signal alteration in occipital lobes. The presence of gyral enhancement, here, the gyral enhancement supports cortical necrosis and the condition will be irreversible. But you can preserve the parenchyma by your early and rapid diagnosis. We are not need for this differential diagnostic list because we have clinical and radiological clue. You have also to analyze the image carefully on T2 and flare to prevent irreversible damage or neuronal loss. Case 3 again is for a 55-year-old female, poorly controlled diabetes with psychosis and chorea-like movement on the right side. The presence of chorea-like movement in diabetic patient should allow us to analyze and evaluate carefully the basal ganglia, because the basal ganglia is a metabolically active structure and liable for the presence of signal alteration or CT density changes in patient with movement disorder. Here, the patient have chorea on the right side and the basal ganglia on the left side is hyperdense with no mass effect, no surrounding edema. It's not hematoma by the Hounsfield unit or the attenuation coefficient and is not calcification. There is corresponding high signal on T2 and variable signal on T1 and variable signal on T2 weighted image. There is no need for differential diagnosis in the presence of chorea-like movement in diabetic patient with basal ganglia signal changes unilaterally or even bilaterally in a condition known as hemichorea hemipalesma syndrome. It's very important situation to pick up any hyperdensity on CT in a chorea or the movement disorders. Case 4 is for 27-year-old male with palpitation, sweating, and confusion. MRI was performed initially for a clinical suspicion for ischemia. Here there is bilateral symmetric restricted diffusibility on the diffusion weighted image and ADC. Other areas of restricted diffusibility are in the corona radiata, hippocampi, posterior limb of internal capsule. The bilateral symmetric involvement should exclude the presence of ischemia. And you have to consider an important situation which is emergent in the emergency department with predilection of parieto-occipital loops with restricted diffusibility, other locations as we mentioned, in hypoglycemic patient. So this is a case of hypoglycemia, which is common condition in neonate or in adult with predilection for the parieto-occipital loops. Why this is emergency situation? Because the changes could be reversible and all the changes on diffusion can be reversible after 2 hours from the correction of the blood sugar level. So a parieto-occipital loops with restricted diffusibility has only 2 differential diagnoses, ischemia and hypoglycemia, and don't forget hypoxic ischemic changes in neonates. You have to check a blood sugar profile in a neonate or in adult with this characteristic imaging feature. So in any case with abnormal glucose level, a timely and accurate diagnosis are needed in order to start your correct treatment and to limit neuronal injury in the early stages, which could be irreversible in some situations. Case 5 is for a 44-year-old male with a severe headache, ataxia, and confusion 1 month post-renal transplantation. Our clinical clue here is the transplantation status. This is because there is a broad spectrum of diseases can occur post-transplantation. Hepatic, renal, bone marrow transplantation. So this patient is risky, and the clinical data is very important. MRI detect infratentorial lesion with variable signal on T1, and it exhibits thick enhancement on post-gadolinium. The lesion is intraaxial, but because of its close relation to the dura, okay, so there is, it looks like extraaxial, but it is an intraaxial in location with thickening and enhancement of the nearby dura. On diffusion here, there is restricted diffusibility in the wall, okay, with restricted inward projections from the cavity or from the wall, and no restriction of the center. This rules out the presence of a pyogenic abscess. Another diagnostic possibility in this patient is lymphoma in a case of lymphoproliferative disorder, and we can exclude it by there is no hypercellularity, and there is MRS also can help in diagnosis, but there is a characteristic, another clue, which is the pluming signal on T2 star. So this carries the risk for iron deposition, and the restriction here in the wall and for inward projections could be attributed to the presence of peripherally located hyphae in fungal infection. So the fungal abscess can occur in an immune-compromised patient, no restriction of the cavity, but the characteristic is the restriction of inward projections of fungal hyphae, as well as the pluming signal subsequent to iron deposition. Case number 6 is for 56-year-old female oncology patient also on chemotherapy with cranial nerve palsy and fever. The clinical situation of every patient is very important. Here, there is on CT extraaxial mass. The extraaxial mass wrapping around the wing of sphenoid, okay? But here, there is no bone destruction, and there is no bone hyperostosis, ruling out the presence of meningioma or hemangiopericytoma. So it is not meningeal origin tumor. On MRI T2, look here, the mass is hypointense. It's not only hypointense, but also the adjacent sinus is hypointense. نرجع تاني لل-CT bone window. Here there is thickening and sclerosis of the wall of the sphenoid sinus. On post-contrast, there is avid enhancement of the mass and also enhancement of the sinus apart from the breakdown area. We can confirm that it is not neoplastic by mean of MRS, no choline profile, but the T2 hypointensity of the mass and of the sinus, as well as the enhancement of the mass and the sinus, should put an important diagnosis, which is also its inflammatory pseudomass subsequent to fungal sinusitis. So it's atypical aspergillosis in an immune-compromised patient. You have to interpret the nearby structure like the sinus, like the orbit, for example, other paranasal sinuses to confirm your diagnosis. So case number 7 is an 18-month-old child with minor trauma, no fracture anywhere, and there is a history of cephal hematoma and bleeding from the umbilical cord as a newborn. There is no major trauma, but CT here reveals the presence of bifrontal extraaxial hematoma and another hyperdense hematoma. Why the hematoma in this acute setting? One is isodense and the second is hyperdense. Okay. After that, the hematoma extraaxial is evacuated, okay, and newly developed subgaleal hematoma is developed, okay. Later on, the hematoma recurs, but to a lesser extent. The clue here is neonate with isodensity of the hematoma, so you have to consider coagulopathy disorders. It's not hematoma hyperdense in the acute setting. It's isodense. Isodensity meaning that there is coagulopathy disorder, and in neonate there is an important condition known as congenital afibrinogenemia, which is a need for immediate fibrinogen substitution to avoid recurrent hematomas or bleeding anywhere. So this is an emergency, and you have to consider it in neonate after excluding the trauma and other bleeding or coagulopathy disorders. Case 8 is for a 1-year-old boy with fever, disturbed conscious level, few days after upper respiratory tract infection. The clinical data here is very important for the deterioration neurologically after upper respiratory tract infection, particularly if it is viral. Viral infection in child or in adult, you have to look carefully for the thalami. Here, the thalami on CT are with bilateral symmetric hypodensity, and there is bilateral symmetric hyperintensity on T2 with corresponding diffusion restriction. In case of a child with infection, you have to consider two important situations. The first, and it is the most common for diagnosis, is the acute necrotizing leukoencephalopathy, okay, in bilateral symmetric manner. And the second is the presence of deep venous sinus thrombosis as a sequelae of this infection. But here, look for the deep venous sinus, the deep venous system. Here, the veins are of preserved flow void signal, and you can confirm by means of MRV. Don't hesitate to ask for MRV to exclude the venous sinus thrombosis. This case is serious and fulminant, but you can save the life by your early diagnosis. So acute necrotizing leukoencephalopathy is an important condition for any viral infection in child or adult, particularly in COVID or post-COVID cases. Case 9 is for a 23-year-old postpartum female, 2 weeks later followed by paresis of the lower limbs, and her sodium level was 160. الديتيلز بتاعت الصوديوم ليفل احنا بننسى ان احنا نطلب to check out اللاب بروفايل of any patient. دي حاجه مهمه جدا ان الريفيلر دكتور to give me full details عشان اعرف اعمل early diagnosis. احنا عارفين ان دايما الهايبوناتريميا هي اللي مشكله، لكن انا عندي هايبرناتريميا واحنا عارفين ان النورمال ليفل is 145 لكن انا عندي 160. في الام ار اي there is bilateral symmetric hyperintensity located in the posterior limb of internal capsule, hippocampi, and here on coronal there is flask-shaped signal alteration along the corticospinal tracts. This is the anatomical course of the corticospinal tracts, with abnormal signal again in the splenium that shows restricted diffusibility and pluming foci on the susceptibility weighted or on the T2 star. So the involvement or the predilection of the corticospinal tracts should raise the diagnosis of what? Motor neuron disease, such as amyotrophic lateral sclerosis. But here there is no clinical data for such. There is no weakness, no muscle atrophy, but it is postpartum female, hypernatremic, okay, with acute onset of paraparesis. What is the scenario? The scenario in this patient is a new developed situation called postpartum hypernatremic osmotic demyelination. كلنا عارفين الosmotic demyelination or osmotic myelinolysis after correction of hyponatremia, rapid correction of hyponatremia. لا الهايبرناتريميا كمان بتعمل osmotic demyelination ومحتاجة ان انا اعمل gradual correction of this sodium level to avoid irreversible neuronal damage عشان ما يحصلش later on damage for neuronal tract. فأنا بس محتاجة 1 minute للlast case. Okay, so hypernatremia is very important emergency situation زي بالضبط hyponatremic myelinolysis. And this is the top differential diagnosis is motor neuron disease. لكن الكلينيكال of the patient والlab profile بيساعدني to narrow this differential and to exclude this motor neuron disease. The last case is for a patient following decompressive craniectomy. After resection of meningioma, and 1 week later the patient develops a neurological deterioration. CTA was done here, sagittal with corresponding axial image for the post-craniectomy status, okay, or the post-craniectomy, immediate post-craniectomy time, and here reveals the presence of residual or the presence of post-operative hematoma and wide craniectomy and pneumocephalus. 7 days later, in the evaluation, look here for the inward sinking of the flap, okay? Distortion of the brainstem and the obliteration of the CSF spaces or the subarachnoid spaces. 24 hours follow-up, the flap recurs without any intervention. And the CSF spaces recurs to the normal condition. So what is the cause for this inward sinking in the post-operative status? This etiology here is the paradoxical cerebral herniation in post-operative status. Should be managed immediately by cranioplasty to avoid cranial nerve pulses. And you have to ask for this etiology. Is it positional? البيشنت بيحرك البوزيشن بتاعه او راسه او ان في atmospheric causes او even ان ممكن يحصل CSF leak. يعني بعد ما بنعمل exclusion لل CSF leak اوكي لازم يتعمل لها immediate cranioplasty to preserve the brain parenchyma. So the diagnosis will be the paradoxical cerebral herniation, which is a surgical emergency and is in need for immediate cranioplasty. Thank you so much.
Any questions?